Hello and welcome. My name is Dr. Anne-Marie Baird. I'm chair of the ISLC's Communications Committee. I am also a senior research fellow in Trinity College Dublin here in Ireland and president of Lung Cancer Europe, which is a non-profit umbrella patient organisation. I, along with the esteemed panellists we have here today, will be discussing the effects of disparities in lung cancer care and research. So we all know that we still live in a world where unfortunately people's outcomes are determined by socioeconomic status and geographical location, and this increases the disparities that people impacted by lung cancer face. These impacts can be wide-ranging in terms of access to early diagnostics, treatment, care, clinical trials, and supportive services. Barriers can be anywhere between just lack of availability to difficulties with language, health literacy, technology access, or sometimes it's just a general bias. So in this press briefing, we will get a flavour of some of the data that's going to come out at this World Conference on Lung Cancer around disparities in lung cancer care and research. And I would ask you to look at all of the other data that's out there, not just what we're covering here in this press briefing today, and really get out there, engage, and give this a voice in the lung cancer community. So it is my very, very greatest pleasure to introduce our patient research advocate on this panel today. That's Mrs. Jill Feldman. Jill was diagnosed with lung cancer at just 39 years old. She was already involved with longevity as a patient advocate at that time, compelled by so many close family members who died of lung cancer. A 12-year survivor, Jill has seen the lung cancer landscape change due to research advances, regulatory approval changes, and now, of course, the COVID-19 pandemic in which we find ourselves. During that time, Jill has also witnessed the real-world impact of disparities in lung cancer care and research. Jill is a past member of the IASLC Supportive Training for Advocates on Research and Science, also known as the STARS program. If you don't know it, go check it out, which aims to increase the numbers of PRAs equipped to provide accurate scientific translation in their online and real-life groups, and for people impacted by lung cancer and their caregivers, and to provide the patient perspective, which is so important in lung cancer research and policy. Jill is also a member of the ISLC's Patient Advocacy Committee, as well as co-founder of the EGFR Resistors. As Chris said, we're asking people to please hold their questions until the end of the press conference, as each time you can ask your questions either live or via the chat function. So to get us started off, I would like to introduce our first presentation, which is from Mr. Gang Fun Loer, who is a PhD candidate at Sun Yat-sen University in China. He majors in epidemiology and medical statistics and does research in global trends in cancer incidence. He is discussing abstract 3090 in place of the conference presenter, Ms. Yangting Zhang. The name of his presentation is Global Patterns and Trends in Lung Cancer Incidence, a population-based study.
Okay, thank you. Let me share my PowerPoint slides. Can you see my slides?
Yes, we can, thank you.
Okay, thank you. Hello everyone, I'm Ganfeng Luo. Thanks for having me here, and I will give a short report about our study titled Global Patterns and Trends in Lung Cancer Incidence, a population-based study. We do not have any relevant financial relationship to disclose. Our study aimed to examine the latest geographical patterns and temporal trends in lung cancer incidence from 1978 to 2012 in 43 countries. Especially, we aim to explore the changes of local health effects and PRA effects to better identify high-risk target populations for primary prevention and provide clues to understand the causal factors. Data were drawn from cancer incident in 5-continent database, Joint point regression model was performed to examine temporal change by average annual percent change. Age-peer cohort model was performed to explore the changes of both cohort effect and period effect. Cohort effect represents generational changes in prevalence of causal factors, such as specific lifestyles and environmental carcinogens. Period effects reflect changes in factors that simultaneously affect all individuals during a particular time period, such as diagnostic practice and screening. Figure 1 presents age-adjusted incidence rates of lung cancer per 100,000 persons by 43 countries in 2008 to 2012. Blue color represents male and red color represents female. As we can see, the highest rate occur in Turkey for male and Denmark for female. The right side in this picture is male versus female rate ratio. Obviously, sex disparity were detected in most of countries, and the ratio existing will found if the ratio existing 5 will found in 5 countries, and ranging from 2 to 5 will found in 22 countries. Figure 2 shows temporal change in race from 1978 to 2012. Light three hollow symbol are for male and solid symbol are for female. For the whole picture, race among females have increased in most European, North American, and Oceania countries, while those among males have decreased, and race in Asian countries remain stable for both sexes. Figure 3 displays average annual percent change in race over the past 45 years by the most recent rate in 2008 to 2012. The x-axis represents the most recent rate and the y-axis represents average annual percent change. From this figure, we can note that most countries among males saw moderate decline trends, but race was still high in 2008 to 2012. And among females, most countries had moderate rate, but saw sharply rising trends, especially Germany, Norway. And besides, Denmark, Canada, and the Netherlands not only had high rates, but also saw rising trends. Figure 4 shows the changes of incidence rate ratio by cohort effect in the left panel, with blue line for male and green and red line for female, and period effect in the right panel, with green line for male and orange line for female. Among males, the reverse V-shaped trend in cohort effect was detected in almost all countries, and the highest rates mainly occur in the 1930 to 1950 birth cohorts. The same pattern was also found in some countries among females. Besides, among females, the increase of risk was steep among early birth cohort and then decelerated for cohort born since the 1930s. And we should also pay more attention to this country with increasing risk among recent generations. Figure 5 shows the changes of both cohort effect and period effect in American, Asian, Oceanian, and African countries. And these patterns were similar to those in European countries. Based on our finding, we can draw the conclusion that disparities in lung cancer incidence and carcinogenic risk persist worldwide. The disparities between the sexes in both race and both cohorts may reflect the sex difference in underlying risk factors and pathogenesis. Our study identified high-risk populations with cohort-specific increase in risk and highlight the urgent need for etiology studies to identify the reasons. That's my presentation. Thank you very much.
Thank you so much for that presentation. That was great. So as I said, we will hold questions to the end and we will go on to the next presentation as part of this press briefing even. Our next presenter is Dr. Wei Zi, who is a PhD candidate at the University of Wisconsin in Milwaukee. Research interests include social determinants of health disparities among LGBTQ people, racial minorities, and immigrant populations. The abstract number for this is 3133, and the title is Lung Cancer Screening Utilization and its Correlates in Sexual Minorities, an Analysis of the BRFSS 2018. So over to you.
Hello, everyone. Thank you for having me here. So I'm gonna have to, okay. Share my screen. Here we go. Thank you. My name is Hui Xie. I go by she, her, or they, them. So it's been an honor for me to be here representing our team members to talk about this topic. So as you can see, our title of the study is Lung Cancer Screening Utilization, and it's correlated to sexual minorities analysis using a behavioral risk factor surveillance system 2018. So I do not have any relevant financial relationship to disclose. So despite lesbian, gay, bisexual population consists for 2.8 to 9.8% of the whole population in the United States, they are at high risk of lung cancer disparity compared to their heterosexual counterparts, particularly regarding their race, ethnicities, age, income, geographic location, risk factors, and other healthcare access. So many studies have indicated that LGBT individuals are more likely to having smoking initiation and younger age, and also a high prevalence of smoking rate. So therefore, it is significant for healthcare policymakers and providers to be aware the factors that are associated with lung cancer screening among LGBT population. So therefore, our study aims to examine lung cancer screening, and this correlates by sexual orientation, stratified by biological sex at birth. So this is a secondary data analysis. So we're using national representative data from CDC, which is the Behavioral Risk Factor Surveillance System 2018. So eligible criteria for this participant is the people who self-identify as age between 55 to 79 and with no personal history of lung cancer. And also they report their gender and sexual orientation identity in the surveys, and self-identify as a current or former smoker with a smoking history of 30 pack of cigarette per year. So some of the major domain of the predictor are socioeconomic status and health behavior and healthcare access. And our outcome variable is a single question asking if they have CT scan in the last 12 months. Oops. Okay. The journal results is listed here. So if you can see, majority, so almost like 85% of the population are non-Hispanic white, and about 6% are Black Americans, and 6.7% are Hispanic, and less than 0.5% are Asian Americans, and also another racial minority, other racial and ethnic minority. And you can also see there's only 1% for lesbian and gay identified individual, and also about 0.56% of the bisexual identified, and also 0.25% of the other racial, other sexual minorities. So according to our adjusted and binary analysis, we've seen 14.37% of people are actually eligible for lung cancer screening, but among them, only 22.85% of people actually utilize lung cancer screening. So when we're doing logistic regression to examine the lung cancer screening in the last 12 months, in relations to social determinants stratified by biological sex at birth, we see that among male assigned sex at birth, people who identify as gay or lesbian and with poor general health and have no medical cost burden are significantly associated with a greater odds of receiving lung cancer screening. But on the other hand, people who identify as bisexual and heavy drinkers are actually less likely to utilizing lung cancer screening in the last 12 months. So another logistic regression amongst people who are female identified at birth, we did not see the similar patterns. We see that like people who have poor general health and have no medical cost burden are also more likely to utilizing lung cancer screening. So what's our take-home message here? So for lung cancer screening eligibility, we did not see that much like differences by sexual orientation, but for lung cancer screening utilization, we're seeing there's a significant differences by sexual orientation as well as by biological sex at birth. So just according to our study, we've seen like we see that bisexual male are actually less likely to utilizing lung cancer screening utilization compared with their heterosexual counterpart. So our finding is also indicated that the socioeconomic status and also have a significant impact on utilization and eligibility for lung cancer screening among sexual minorities. So future studies should actually address those like economic burden as well as increasing more awareness for about cancer screening utilization among sexual minority, particularly for bisexual men. So that'll be all. Thank you.
Thank you so much. Great presentation and really, really interesting data there where it comes to lung cancer screening. So from that, we're going to move on to our next presentation, which is Dr. Brandon Stiles. He's an associate professor of cardiothoracic surgery at Weill Cornell Medicine and a thoracic surgeon at New York Presbyterian Weill Cornell Medical Center. He's deputy chair of the IASLC Communications Committee and a member of the IASLC Lung Cancer News editorial group. He is also chair of the board of the Lung Cancer Research Foundation, a member of the LungRAD Steering Committee, and of the AATS Foundation Advisory Council. Dr. Stiles is also well known in the lung cancer patient advocacy community and is extremely active on Twitter. So over to you, Dr. Stiles.
Hi, how's everybody doing? Can you see my screen?
Yes, indeed.
Well, I'm thrilled to be here, and I'm hoping to share what is some good news on this challenging topic. All the panelists are great, and I hope everybody's getting a flavor of it. We wanted to look, I'm gonna go back for just 1 second. You know, we all talked about disparities, but we really asked the question, is there progress there? And I hope that that's what I'll leave you with. These are our disclosures. We have several, but none are relevant to this talk. And this is background. I think it's important to reflect on the rates of 5-year survival, that they're so widely different. They've been suggested to range from 56 to 92% for stage 1 lung cancer. And I would ask you to take a minute to think about that. That's a pretty remarkable and eye-opening range of survival. If we could just universally increase survival to rates already obtainable and reported at some of these centers with some populations of patients, we could potentially save tens of thousands of lives. Obviously, several factors contribute to these differences in survival, and that includes tumor factors in biology. There's just some bad tumors, but there's also diagnostic and treatment differences. Are we staging patients adequately? Are they getting guideline-based therapy? And the sad fact of the matter remains that socioeconomic factors are still associated with survival in many studies. These differences have particularly been brought to light by COVID, where they've become a part of the national conversation, but unfortunately, as you've heard, they're present in cancer too. Previous analyses from the National Cancer Database, for instance, have shown that socioeconomic risk factors, race, education, insurance, and income, were associated with 10 to 20% absolute decreases in 5-year survival. Even in countries like Sweden, where there's universal health care, low disposable income has been associated with changes in staging and treatment of lung cancer, and with a 23% increased rate of death in low-income patients. That's pretty incredible to think about, and I think it means that we're losing potentially 1 out of 10 or 1 out of 5 lung cancer patients in part because of income differences, which really should not be. Unfortunately, it's an often repeated story about which a large body of literature exists, however. So we wanted to do something different and maybe look at some of the positives. We've all heard about the tremendous gains in cancer survival. The record decreases in mortality from cancer have been reported by the ACS the last 2 years and have made great headlines. This has really been led by lung cancer, in which there's been about a 5% drop in annual mortality. What we really wanted to know is whether the most at-risk patients are also enjoying these improvements. Are they spread across the board? So we took the National Cancer Database and we examined those patients. This ended up being a study of almost 50,000 patients who were in the lowest income quartile, less than $38,000 median income. And then we divided it into 4 time periods that you see here, spanning over about a decade of care. And what we found was pretty remarkable. Over time, patients were importantly less likely to get no treatment, 15% in time period 1 to 12% in T2. They were less likely to get chemoradiation, which we would consider not the standard of care for stage 1 and 2 lung cancer. And they started to become more likely to get radiation, probably as stereotactic radiation became more available, and more likely to get surgery over time, 57.9% in T4 versus 52% in T1. Now, these may not sound like huge differences, but when you apply them to the large population of patients who have lung cancer, it really can make a difference. And importantly, we did better with the treatments. Short-term 90-day mortality decreased steadily from 5.3% at the earliest time period to 3.9% at the latest, and readmission decreased almost 1.5% over the same time. So we're treating more patients, we're treating them safer, we're doing a better job at keeping them out of the hospital. And here's the punchline: better treatment and probably better staging leads to better survival. At 1 year, 8.5% more of these low-income patients were likely to be alive, and at 2 years, there was over a 10% improvement in survival. So put that in perspective, that suggests that thousands of lives have perhaps been saved in this, our most at-risk population, due to better care, better staging, and better treatment. And yes, we can still do even better. We should get this number above 85% at 2 years, but encouragingly, we're making a lot of progress even in this high-risk group. So then if we know that we're doing better, it's important to understand why and how. We therefore looked at factors associated with survival in these patients, and we found some that are really important. The association with later year diagnosis speaks to the whole theme of this study. If you were diagnosed in a later time period, you were 19% less likely to die. And gender is another, but obviously something that's less amenable to intervention. But if you look and think at the rest, a couple points come out. Earlier clinical stage and improved survival. So how do we change that? With lung cancer screening, we have to get better access to screening for low income or at-risk patients. Treatment at an academic center. Not everyone can get there, but there's potentially more multidisciplinary teams in place, better staging, and better treatment pathways. We should really have low barriers to referral to centers of expertise. And private insurance, obviously coverage matters. We have to make sure that people's healthcare is adequately insured. And finally, surgical treatment was associated with a 51% decreased chance of dying. And sure, some patients may be too sick for surgery and therefore experience poor survival regardless. But it's important to let the surgeons evaluate these patients and not make decisions for them, particularly based upon socioeconomic considerations of the patients. We're pretty good at surgery these days. We want to take great care of all patients, no matter their socioeconomic background. So my take-home messages are these: that disparities exist, but efforts have been made to address them. And encouragingly, over the decades studied, short-term mortality and hospital readmissions have decreased, and short-term overall survival has improved in low-income patients to pretty remarkable levels. I think we can hopefully keep this pace going. In addition to a later year of diagnosis, treatment at academic centers, private insurance, and surgical treatment, were each associated with improved survival in these low-income patients. And that's all I have, and so thanks so much for including me in this press conference.
Thanks so much, Dr. Stiles. And I should have said the poster ID number for that study is P08.04. So now we'll go on to our next presentation of this briefing. I don't know why I can't say briefing today. I'd like to introduce Dr. Sitapriya Mortis, who is a postdoctoral research associate at the Alice Berger Lab at the Fred Hutchinson Cancer Research Center. Dr. Mortis' research interests include defining the genomic landscape of lung cancer in never smoker women, identifying mutational signatures that define this cohort, and correlative analysis with behavioral and environmental exposures to identify lung cancer etiology. Dr. Morty hopes someday to identify germline or hereditary components that could influence lung cancer in never smokers. And Dr. Morty's featured poster is number FP12.12, which is Lung Cancer in Women Never Smokers, a genomic perspective of the Women's Health Initiative cohort. If you'd like to start, Dr. Morty.
Hello, can you hear me now?
Yes, we can hear you.
Okay, great. And you can
Great.
see my slides as well?
Yes, we can see your slides. Thanks so
Okay.
much.
Great. Thank you so much to everyone for giving me this opportunity to give you a brief overview of what we're working on and why we're working on this subject matter. As was mentioned, my name is Sita Priyamurthy. I'm a postdoc in Dr. Alice Berger's lab. And the topic that I'm currently studying is looking at the lung cancer in women, specifically postmenopausal women who have no history of smoking, but still do develop lung cancer. And the idea of my work is really to bridge together the aspects associated with the genetics of this disease to the vast amount of metadata that has been collected as a part of our collaboration with the Women's Health Initiative to really address key specific issues in this field that still remain to be answered. For more specifics of the data, I'd encourage you to please go look at my poster. But what I really want to bring here today is what are the issues in this specific area of research that are still lacking and what we try and hope to address through my work. I do not have any relevant financial disclosures to disclose. Okay, so lung cancer in never smokers is a very vastly understudied area in the field of lung cancer. And one of the reasons is because there is no very clearly determined risk factor. Historically, it was imagined to form a very insignificant proportion of the total lung cancer burden. But as tobacco cessation programs across the world start kicking into gear, what we're seeing is a reduction in the number of cases that are primarily due to tobacco, and what is deemed to be an increase in the number of cases in never smokers. Again, this is a highly contentious part where people are questioning whether really the total number of lung cancer cases in never smokers is increasing, or is it just its proportion? However, that being said, what we do understand is the proportion of individuals diagnosed with lung cancer in any geographical area per se, it does form a significant portion of the total number of lung cancer cases being diagnosed. In fact, some studies suggest that if you considered this disease as a separate entity, it would be the 7th largest cause of death due to cancer. So it does require attention. And it does require an understanding that is distinct from our current understanding of lung cancer, which is heavily based on individuals who have been smoking. So this is a study that was done back in 2007. It is a bit dated. However, it sends the message across very clearly that never smoker populations do form a significant proportion of the lung cancer cases, whether you look in countries in Europe or anywhere across the world. But what it also interestingly reveals is that there seems to be some geographical bias in the total number of cases being diagnosed. And what has been noted by this study and several more recent studies as well is that in Asian subcontinent, we see a larger proportion of the cases that are lung cancer being diagnosed in individuals who have never smoked. And that is perhaps one indication to potential either genetic predispositions or environmental components that could be skewing the graph in that direction. Another very important aspect of lung cancer never smokers that I wanted to bring forth was this gender difference that we see. And this has been touched upon by the couple of previous talks as well. But what we do notice is if we're looking at all lung cancer diagnosed either in men or in women, what you do notice is a larger proportion of the cases diagnosed in women tend to be having a never smoking history. And this trend is true across all these different subcontinents. Again, this data, even though it's a bit old, but really captures the essence of what has been observed even in the most recent studies. Another important or unique aspect about lung cancer in never smokers is this histological or subtype specificity, where you predominantly see this adenocarcinoma histology, which could provide another insight into what are the possible biological mechanisms that are really driving lung cancer in this group of patients. So really there are three big questions that come out from all the research that does exist in the field. The first question and the most important question is what really causes lung cancer in never smokers? So thanks to our collaboration with the Women's Health Initiative, which is a combination of 3 clinical trials and an observational study, our goal is really to assess potential environmental and behavioral risks that could cause lung cancer in never smokers and their association with specific genetic mutations. The second question that is really still left to be answered is what is biologically driving lung cancer? And through our analysis of the genetics and the biology, we really hope to address that question to identify key genetic and molecular players that are driving lung cancer. And finally, the question of how we can treat lung cancer in never smokers. And I'm of the strong belief that this disease is molecularly and biologically very distinct from lung cancer that you do see in smoking individuals or individuals with a history of smoking, and should be really treated as a separate entity. And by identifying genes that already either have drugs that target them or are in development, we'll be really able to help individuals in a more efficient manner. So with that, I really like to end and thank all our different collaborators, and most importantly, Dr. Alice Berger, who really has provided this platform. And last and not but the least, all our funding sources, to the organizers and to all the patients who've really contributed to this program, without which I don't think any of this research would have been possible. Thank you so much.
Thank you so much, Dr. Morty, and you really make the case there that we need to look at stratify into different cohorts of people impacted by this disease because it can make such a difference. So I'm going to move on now to Ms. Jill Feldman, who I introduced earlier, and Jill is going to provide us with a patient research advocate summary and some comments as well. So I'll pass over to you, Jill.
Great, thank you. I don't have slides for today, but I want to thank you for giving me the opportunity to speak. This is something I'm very passionate about. Inequalities are prevalent across the spectrum of cancer care and research. They are complex and they are complicated, but I love the Dr. Martin Luther King's quote, "Of all forms of inequalities, injustice in healthcare is the most shocking and inhumane." Lung cancer is the disease that can affect anyone, but it doesn't affect everyone equally. And despite all the advancements in research and treatment in lung cancer, the vast disparities across the cancer care continuum, both in the United States and worldwide, are glaring. They are rooted in a history of discrimination and exclusion that has prevented certain communities from the opportunity to access and receive the care they need and deserve. I got involved in advocacy in 2001 after losing my parents and other loved ones to lung cancer. At the time, lung cancer was considered the invisible disease with little awareness and negligible funding for research. When I was diagnosed with lung cancer in 2009, research was finally moving in the right direction. And as we all know, it continues, thankfully, to rapidly progress with new discoveries and more and better treatment options. Over the past 20 years, I have witnessed and celebrated the creation of a lung cancer community, and I have personally benefited from many of the advancements in research. I am so grateful that my path was different than my parents', and I am hopeful for the future of lung cancer. But it is disturbing and just plain wrong that my good fortune is mainly a result of luck. Simply stated, I was lucky to be born into a white, middle-class family in the United States. Even more upsetting is that I represent only about 20% of people with lung cancer, which means that the advancements in treatment and the hope I have mean absolutely nothing to approximately 80% of people diagnosed with lung cancer. I was happy to see the many abstracts submitted to the Conference on Disparities in Lung Cancer and took the time to read through them. One thing that I think is important to note with the abstracts, and the ones discussed too during this press conference, they point out the importance of context and culture. They highlight that underserved communities are defined by multiple constructs: race, ethnicity, LGBTQ+, gender in general, elderly, people who live in rural communities, and other groups which all face barriers due to inequities in cancer care. And one thing that really struck me that I felt was important is to recognize that the data is more than science, though. A p-value isn't simply a statistic. It is an inequity. It is a deep injustice. It's people's lives. And I was at this advocacy summit last January, and one of the sessions was on disparities in cancer care. And there was a presentation from the African American, LGBTQ+, Latinx, and Native American communities. The presentations were eye-opening and, quite frankly, upsetting in a lot of ways. During the Q&A, I asked the presenters what the best way for me as an advocate would be to reach underserved communities like theirs to ensure that people had certain educational materials and the other resources they need. One presenter looked at me and asked, "How do you know what they need?" I was beyond humbled. I got a quick lesson on cultural humility, which is very different than cultural competence. Competence assumes one has learned all they need to know about another's culture. Cultural humility recognizes that every culture is unique and there are a lot of things we still don't know. In fact, we don't know what we don't know. And there was a lot I didn't know. One presenter talked about a 2016 study that reported 80% of first-year medical students expressed implicit bias against lesbian and gay people, and nearly 50% expressed explicit bias. I was surprised until she mentioned that the average number of hours dedicated to LGBTQ+ health in medical school is only 5 hours, and in nursing school, it's only 2 hours. I learned that Western medicine can conflict with Native values and practices in tribal communities. For instance, a simple biopsy can be significant because their belief is if the body is cut open or a piece of it is missing, when someone dies, the spirit may not properly begin its journey after death. We must incorporate cultural humility into cancer care to foster equity and inclusion. Healthcare providers can't make their own culture the standard. In fact, we all must take steps on each person in their own cultural context. Black people are not a monolith. The LGBTQ+ community is not a monolith. I'm Jewish, and I can tell you that Jewish people are not a monolith. So you can't help a person truly if you don't understand them or know what they need or what their communities need. The context in which people live must be considered in research and care. And the only way to learn with humility requires engaging with the community communities where they live and understanding their unique barriers. Listen and learn about the people in the community and value the input and perspectives they bring to the table. I listened to an advocate from the KU Cancer Center tell a story recently about engaging with an under-resourced community in Kansas. He decided he was going to go into that community and ride the public bus. And along the route, he noticed that when the bus went by Target or Walmart, the bus driver announced it and stopped so people could get off. But when they passed two healthcare facilities, nothing was mentioned. So the advocate called the bus company, talked to them, and asked them if they would announce the healthcare stops and see how he wanted to see how people would react. Well, guess what? The appointments at the facilities went up 30%, simply by individuals being made aware of what was available. And that really emphasizes the importance of always asking who is not at the table. It's great that we are all here, but who is missing? It is critical to infuse people from underserved communities in all the work that you do. I always describe being diagnosed with lung cancer like one day you're going about your life and suddenly you are drop kicked into a foreign country. You don't know where you are, you don't speak the language, you don't understand the culture, you aren't familiar with the terrain, and you don't have a map, yet you need to figure out how to survive. Now imagine how different the outcomes are between those who can easily access resources and those who have to navigate the foreign territory without any help. We have the research on disparities. We have the data. We know there's a problem. We need to stop analyzing and start actionizing. Health equity must be a priority. We need the same level of resources and rigor that was put into the urgency of COVID-19 research and a vaccine for it. There are regulatory policies, but they only provide the framework for addressing inequity. There has to be a change in culture at every level and a change in mindset by everyone. People are very comfortable talking about disparities caused by external factors, such as governmental policies and historical injustices, but much less comfortable discussing race and discrimination as social determinants that lead to the inequities in healthcare. But change doesn't come from a place of comfort. When I was asked to speak at the press conference and give a presentation on diversifying clinical trials, I questioned whether I was the right person, whether I could speak on behalf of people from underserved communities. But growing up, my mom always taught us that it was our responsibility to fight for what's right. She would say, it's one thing to see something and know it's not right. It's another to be brave enough to go against the norms and do something about it. I may not be able to speak for underserved communities, but I can do something about it. I don't understand what it's like to be a minority, and I understand that I will never understand, but I can and I will stand, and not just as an ally, but as an accomplice. Indifference and silence only perpetuates injustice. So I urge everyone, every company, every institution, organization to stand with me. Take a pledge and commit to self-reflection, to acknowledging the disparities exist, funding minority scientists, embedding a health equity lens into all initiatives and programs, advocating for anti-racism, and to prioritize people over profits in your institutions. And we must not forget that lung cancer itself can be a health disparity that affects both a patient's health-seeking behavior and a physician's perception of a patient with lung cancer. This stigma must be addressed in order for us to make strides in equalizing other disparities. Meaningful changes start with each one of us. It starts here, it starts today. In the words of JFK, every accomplishment starts with the decision to try. Today, I am asking you to make the decision to try. I am asking you to stand, and I am asking you to join me and shoulder the burden of knowing, the burden of lives that depend on us. Thank you again for allowing me to speak on behalf of the lung cancer community.
Jill, thank you so much. I mean, it's yeah, lost for words, to be honest, because that was just such a great talk and so inspiring. And you've really, I think, given a huge food for thought. And I really feel that your talk here today is really a rallying call and a call to action. And I hope that the ISLC and members of the ISLC, no matter what your discipline is, no matter what your outlook is, no matter what your culture is, that we can all come together and get behind this call to action. And I hope the ISLC as a global organization can really take that on board and move that forward, because I completely agree with everything you've said there, Jill. And what we always hear about are the disparities. We always hear about, oh, you know, that's a hard to reach population, and how do we reach those hard to reach populations? But yet, if you look into it further, nobody's ever gone to try and talk to the hard to reach population as to how they should reach them.
Mm-hmm.
Because it's in the too difficult basket, and it's in that, well, we don't hear anything from that ethnic minority or that part of town or whatever the case may be. So we really, I think we can't just continue to talk about it and fob it off. It's, you know, like, oh, well, hard to reach, we'll leave that there. As you say, Jill, we really, really have to get behind this, and we really, really have to do more. So thank you so much for that talk. And I hope everybody here will take on board what you've said today. And I think as well, the flavor of the presentations we've had here in the disparities in healthcare and in research, we can see that there's gender bias, we can see that there's socioeconomic bias, geographical bias, sexual orientation bias. I mean, I think really whether it's a bias that you can identify within yourself, these biases are there and they exist. I mean, talking to other people in the patient community through the work that I do, a lot of people feel that, you know, they're supposed to be involved in their person-centered care and shared decision making. But what is found is there's an implicit bias there with the clinician who automatically decide, oh, well, you know, I'm not going to put you forward for that clinical trial. You know, I don't think you should have this treatment, but the conversation isn't there. Whereas if someone else comes in from a different background, it's like, okay, clinical trial here, we could have this drug, we could do that. And it's a very, very different conversation. So it's not even helping to empower people to find out more about their own disease and the options that could be open to them. Because of course, in doing that, we'll really open up the conversation and find out more about what that person needs and what can be done to help improve outcomes within that community. So I think there's a huge amount to be done here. And I mean, I had made some comments, but you've covered them all, Jill, to be honest. I think we have to be cognizant of the fact that whatever approach we take, one size does not fit all, one approach is not going to fit all. And as you said, Jill, it's really those cultural differences and the understanding, the sensitivities, the respect of those cultural differences and the impact that might have on the care pathway for people impacted by lung cancer. So I think there's a lot to be done in this area, but I think the more we can talk about it, the better. And as you say, Jill, you know, there's an 80% group impacted by lung cancer that don't really get that seat at the table at all. You know, it's a huge disservice. We talk about what we don't know when it comes to something like molecular testing, but you think you've got a whole 80% cohort there. You don't know what you don't know in there either. So why can't we look at it in the same line of treatment options, biomarker testing, and so on. We can't be picky and choosy just because something's easier or something we're more comfortable in. So that's just my thoughts from this session. I think there's a huge amount more that the IASLC can do, that members can do, and hopefully people taking part in this today will really engage through social media channels and other channels to really bring this to the fore, because, you know, we have to bring everybody with us. Let's not leave people behind. You know, there has been so much change within the lung cancer landscape with treatment, with you know, innovative care therapies, but that's not really a true improvement for this community unless everybody can access that, unless everyone can bring it forward, and unless everybody can see the benefit of it. I mean, one of my things is people talk about individualized care, personalized medicine, and just because people say it so often, they think everybody has access to the same thing they have. That's not the case, so let's not kid ourselves. You know, let's have a bit of a reality check and try and do something about it. So that's just my comments from this press briefing. I'd like to thank all the presenters for their fantastic talks and their really great research. I'm just going to open it up now if anyone has questions, or I'm just having a little look at the chat. Chris Joy, maybe, I don't know if there's maybe some questions there that I can't see.
Looks like Caroline has posted a question. Caroline from ASCO Post to Dr. Mortai. Did you see that question, Dr. Mortai?
Yeah, I was just typing out the answer, but I can speak on audio chat. So yeah, so a lot of, that's an interesting question. And I guess if you've seen my poster, you would see that I don't have as many MET or RET mutations in my data. And I think I attribute a lot of that to also the cohort we're studying. So a lot of the studies that have been done so far have either focused on younger Asian women. There are very few studies that have, or younger women in general. There are very few studies that have specifically led to, have looked into postmenopausal women. So we were also really surprised when we didn't see RET and ROS and ALK, which are the most commonly associated with lung cancer in never smoking women. We don't see this, and I have looked, but we are reanalyzing some of the aspects of our data. But I can say for sure, we don't see as many regular MET and RET mutations that we would expect.
I did the usual Zoom thing, didn't unmute myself even after all this time. Are there any other questions from anyone here?
Well, most of us will stay in the chat until at least 10 or until everyone has left. So if you do have a question, you can also email us afterwards. I'll make sure that your question gets to the doctor that you're interested in talking to. If you think about a question later on or want to in the middle of doing a story later today or over the weekend.
Yeah, Chris, I might just ask one question, just in case anyone else is wanting to get something down in chat, to Dr. Stiles. Just the data that you showed in your presentation, what do you think made the biggest difference there? Is it a case that clinicians were addressing their own bias? Like what do you think, or is there something that you can put your finger on that like made such a change or made such a difference?
Well, I think it's probably all the things that have lifted up the lung cancer survival rates in general, better staging, earlier diagnosis, and probably higher utilization of things like surgery and stereotactic radiation for early stage patients. We suspect, and the field suspects, and there was an article in the New England Journal earlier this year that we're going to see an even higher uptick due to targeted therapies and immunotherapies in later stage patients over the next several years. There will be challenges there and making sure that those go to patients with disparities as well, making sure they get proper comprehensive biomarker testing, making sure they have access to those drugs. And so I think we just wanted to lay the stage and see what kind of progress we've made in this high-risk group. I suspect there's lots of factors that have contributed though.
Thanks. And then I just had, Chris, if it's okay, just one other question to Dr. Morty. Like, such interesting research there. And I'm just wondering, like, I'm a scientist by background, by day job. And one of the things I see is that, you know, a lot of sort of the in vitro and in vivo models that are used in research, it's male mice, it's male cell lines, it's, you know, this type of thing. And, you know, you're applying drugs or different treatments or making changes, and you're making, I guess, inferences from that without really considering the sex differences. So I'm just wondering, you know, in the research that you guys are doing, are you finding it difficult in terms of maybe if you're going back to basic translational models, or how are you addressing that within your studies?
That's a very a good point. So yes, so based on my study so far, we're purely looking at samples directly from patients. So as of now, our research or our results are not biased at an additional level. But yes, I do agree. If we were to use the traditional mouse models or the traditional cell line models, that would be a fair fair critique of the work. But I think our vision for this project is to really look at PDX models or patient-derived 3D tumor models, and not really go with those traditional routes of investigation. And I think that's a very important aspect that you do bring up, because a lot of studies, especially the molecular studies, really stem from things that have been generated years ago or have been traditionally used, obviously because of ease of use, which is an important aspect in an expensive area of research like genetics and molecular biology. However, they introduce so much bias that we're not even aware. And so a lot of the scientists in the room will totally agree, where you have a model that has worked out really well in one cell line or one kind of mouse model, and you move even into another kind of cell line with what you assume are the similar genetics, and you do not see the same molecular model hold up. And that's kind of reflective of how our research should also be unbiased, or must be bias aware when we're looking at those things. So that's an excellent point that you bring up. Actually, I had a question to the group, if that's okay.
Yes, of course. Go ahead, please.
So I've been hearing from Jill and Dr. Stiles for sure for a long time about the bias that does exist. And as a young postdoc, like, what my big question is always is, we've identified a lot of problems that we do see in recruiting a diverse group of individuals to clinical trials. But could you share with us, or anyone in the group could share with us, some of the strategies that have been successful at recruiting and people of diverse backgrounds into clinical trials, which I think is ultimately the most important thing?
That's a great question. No, go ahead, Jill.
I was just going to say that as far as strategies, since I don't do research, I don't necessarily have any strategies. I've reached out to different advocates who are, really advocate for health equity when I was going to talk here. And I also did, because I spoke when I think it's on Saturday, I am presenting on diversifying clinical trials, and reached out to people as well. And interestingly, again, kind of the same themes in terms of having to engage with the community, reach out to the communities. It's critical to understand where they live and involve them from the beginning, and collaborate with community hospitals and minority physicians, all of that, and one other thing is partnering with patient groups. And there's the Metastatic Breast Cancer Coalition. They did a research study that actually showed the improvement of accrual and clinical trials when they engaged with a patient group. So, and the only other thing is, I think, you know, one of the themes too is, again, you building a relationship between the research community and the under-resourced community. We know that it's not just enrolling in clinical trial. We know that in precision medicine won't be precise if we don't understand the biology of the disease as well in different cultures. So it's like, you know, interesting. It's a vicious cycle because you've got, you know, the lack of diversity in trials with issues to access leading to issues of understanding tumor biology in the different populations, which lead to the issue of the lack of generalizability. So all of those things that I mean, again, I'm not a scientist, but reaching out to those in, you know, deep in the health equity advocacy space, those are some of the things that I guess they told me.
And I'll be brief. It's a great question. I think, you know, first and foremost, you have to have researchers and clinicians who look like the patients, right? And so the institution has to believe in diversity and truly champion that. That's a big part of the reason I'm going to Montefiore to help do that. I think you have to talk in patients' language and make them trust you. And that's, you know, some learning and social learning, but it's some through materials as well. It's with engagement with community groups, churches, restaurant associations, anything it takes to reach that community. And then I think we need to incentivize more research. And we've been proud, for instance, at the Lung Cancer Research Foundation to sponsor disparities grants the last several years. You just have to get people interested in the space and understand that it's an area of great need. And ISLC has done a great job in that area as well. And I think we'll continue to see more.
Yeah, absolutely.
Yeah. So according to what has been done in the past related to, like, you know, community engagement programs or interventions. So I also, it will depends on what kind of minority or underserved population you're targeting. If you're targeting, so for instance, if you're talking like sexual and gender minority, you might actually looking for a gay person who actually has the network, so they can actually help you out to like reaching out to office services, and also like listen to the community what they actually need. I'm pretty sure, like, as a researcher, we all have some kind of biases, right? So like by intervening or by providing any kind of services, you want to know whether you providing actually meet what they actually need. So I think it's very important to actually listen from them, what they're actually looking for, what they need. So that's actually what I'm getting from if you're doing any kind of study that involving sexual and gender minority, but also with, like, you know, racial ethnic minority. There's a little bit differences because a lot of like racial and ethnic minority in the United States might be foreign born. So in that situation, you're also looking for some people who actually understanding those like transnational cultures that give you some sense of like what they're like, you know, originally believe or cultural belief of like Western medicines, how they're practicing preventive care, right? Because a lot of like, especially East Asian immigrants, they maybe not actually utilizing any preventive care, not just because like socioeconomic status, but also just like in their cultural belief, this is not where we kind of things they're doing until they're actually getting to see the disease that actually impact their life. So things like that, you also have to acknowledge that, like, you're looking for some people or scholar or like people from the community actually, you know, talk with you and create dialogue spaces. People can, you know, providing their understanding about how they see the program, maybe able to be more like culturally humane, you know, or culturally comprehensive enough to build a bridge. Yeah.
I just want to add too, I think it's something that people are very uncomfortable with it if they don't understand it. But I can tell you from, you know, reaching out at first, I as well, but all depending on the different communities, they're all they care about is that you're trying to, you know, recognize their unique differences, that you're trying to learn. And it is humility. It is saying, sorry, I screwed up when I, you know, messed up, or I am sorry, I said that wrong. It's not due to the color of your skin. These disparities are due to racism. So, you know, it's like those little differences that you just learn, and it's just really, truly, I don't know about anybody else, but I've gotten such great help and feedback, and they are happy to have people care about their interests and their needs.
Mm-hmm. I think, Jill, you know, you make such a great point there, and it's really, you know, we talk about language in terms of how we talk about people impacted by lung cancer, and I think it's the language in that approach as well when you go to other communities, because I think people do have a feeling that, oh, I know everything about that community as well as my own community and all of those, but really you might just be skimming a tiny bit off the top of the level and you have no idea what's underneath the surface. And Dr. Z, I really liked the point that you had when you talked about the studies and how to approach, but I'm just wondering, like, is there any kind of, at your center or that you know of, are the kind of things that you're bringing up, is there like a metric in any way? Is it measured in any way? Is there something that can be done, whereas, I don't know, is it people would have to meet certain targets? I have no idea, but I'm just wondering, sometimes when you put sort of metrics behind things, it can kind of sometimes give it a little bit more of a push. So I'm just wondering, in your experience, is it something like that, or is it something completely different?
Well, it's very hard to say, but this is in generally for like lots of LGBT study, primarily for like United States, is still like primary focus on HIV preventions, and also like, you know, stigma related, like, you know, mental health prevention or reduction. So lots of time, like, you know, especially for cancer screening, it's still kind of left behind, within the, even within the LGBT communities. So also I understand that's like, it's very hard to talk about, you know, people's, you know, personal life, and also as well as like how they're actually determining their like preventive care. So I hope, I mean, there's definitely lots of like great study been working on across the country that focusing on cancer screening, but unfortunately, because the sample size and also maybe the study design is still very limited and behind. So hopefully we are able to have more, national level, like study actually, highlighting this like cancer screening disparity as well as like cancer care disparity. So far, I mean, the last couple of years, CDC have been put up some really great, like, documents that are focusing on that, but still, we still like looking for more, community and scholars that, advocates for this kind of prior-oriented and focus for the minority, particularly like LGBT population, especially like for now, it's the transgender population. It's also have been like highly like, yeah.